Dr. Mary. Ryan Baumann. I'm not used to the last part that it's me. So we went to graduate school together, and she's done a lot of really interesting work in the clinical trial space. So today she's going to be talking about cluster randomized and step-wedge trial designs. I'll let Mary go ahead.
And thanks so much, Michelle. And thank y'all for either coming out in person or coming in on Zoom. Yeah, I'm really excited to talk to y'all today about a couple of areas of my research, which are around cluster randomized and step wedge trials. And this title is a little vague because I'm trying to combine several different projects here into one. So I hope it'll become more clear in a bit. To kind of start off and contextualize what I'm going to talk about, I think it's helpful to talk about what the buckets of my research tend to be in. I tend to do a lot of work in general trial design spaces. I do a lot of work on trial monitoring and specifically interim trial monitoring, work in study recruitment and retention practices. I've done a lot of work, as Michelle knows, in kind of the Alzheimer's disease and related dementia space. And more recently, I've been active in the cluster and pragmatic trial design space. And so where I really describe my work as kind of the intersection of these three buckets, and how I kind of describe that is kind of all the weird ways that we need to smash together kind of statistical theory and practice, or kind of the conflation between the trials we would like to ideally design if we had a perfect amount of resources and time versus kind of the situations where we need to modify those designs to meet the world and meet our research teams where they are with their kind of resources and feasibility constraints. So in that kind of mindset of kind of adjusting ideal trial designs for the real world, I'm going to talk about a couple of different projects today in the space of cluster randomized and step wedge trials. I'll first give a little bit of an overview to what these types of trials look like and some of the statistical considerations we take when we're designing these trials, and also introduce some of the consort extensions that were introduced over the years to inform reporting. And then I'll talk about two systematic reviews that I was a part of that help kind of characterize how people are designing, running, and reporting specifically step wedge trials. And these were kind of two systematic reviews that focused first on kind of just generally recently published step wedge trials in the healthcare space, and then kind of an offshoot review that we did that focused on what we call extremely small step wedge trials to kind of see why people were conducting those and kind of what were the circumstances around those. After that, we'll kind of talk about some common design challenges that we've found through these kind of systematic reviews. And then I'll move into some tools that have been developed over the years to help assist with those challenges. Two of which are not mine, but I just think they're really cool and I always like to talk about them a little bit. And then the last one is the most recent one that I've been working on recently, and we have a new preprint out about. And then I'll kind of wrap up with some conclusions. And if you have questions, feel free to just shout it out. I'm fairly casual, so. Before we begin, though, I kind of want to acknowledge that a lot of the systematic review work I did was in conjunction with an international team of statisticians and epidemiologists. I was just kind of one cog in the machine, and it was kind of captained by Fan, Agnes, and Monica at Yale University de Zurich and the Ottawa Hospital Research Institute. And they are also my collaborators on our latest kind of Shiny Calculator project for heterogeneous treatment effects. So I also want to acknowledge them there and the fact that that work was funded by a PCORI grant. So to start us off, let's talk a little bit about what is cluster randomized trials. What are they? And as the name might suggest, those are trials where instead of randomizing individuals to treatment conditions, we're instead randomizing entire clusters or groups of individuals to a treatment condition as a unit. And here we're defining clusters as natural groupings of participants. So you can think of this as things like schools, clinics, neighborhoods, hospitals, groupings that exist kind of outside of the trial or study space. Now, this is a very old design type. It kind of grew out of the vaccine literature a lot. And some of the reasons why you might conduct a cluster randomized trial is first, you might be worried about what we call contamination or spillover effects. So if you're worried about kind of interaction between individuals in different treatment arms, and if you believe that you have two clusters that do not interact with each other much, you can randomize an entire cluster to a single treatment condition and kind of hope to isolate the interaction between those treatment groups. Where I tend to work more often is in the motivation of where we're really testing cluster or system level interventions. You're still interested in how these interventions influence individual level outcomes, but they're kind of interventions or conditions that can really only be implemented at kind of the top down level. And I kind of label this as the more pragmatic-y side of cluster randomized trials. And you can think of those as, your learning health systems kinds of trials. So like I mentioned, intervention can be at the individual level or the cluster level, even though you're randomizing at the cluster level. And then data collection is usually happening at both the individual and the cluster level. The anatomy of a parallel, what we call a parallel cluster randomized trial, is fairly intuitive. You have a set of clusters, you randomize them to treatment conditions in some sort of kind of allocation ratio. You have individuals within each of these clusters. And you might have potentially unequal cluster sizes between your clusters, depending on kind of the context or the situation that you're in. And in designing these we call these parallel because we have concurrent kind of treatment and control conditions. We only have one measurement observation for each. And here sample size is defined by not just kind of the overall number of individuals in our trial, but the number of clusters N as well as the cluster size M. And kind of in our power calculations, you can see that the cluster size is really coming into this mostly through the variance of the ATE or the overall treatment effect, it being on both the numerator and denominator, whereas the number of clusters is really only coming in the division of the variance of the ATE. So the number of clusters here is far more influential on what your power is going to be than the size of your cluster. So if you're underpowered for these types of studies, it's much faster to boost that power by increasing the number of clusters rather than increasing the cluster size. Usually easier said than done, since recruiting additional clusters usually involves a lot of kind of rapport with community stakeholders and things like that. So it can be at a little bit of an imbalance there. One of the other things you'll also see that plays a role in these power calculations and the variance of our average treatment effect is parameter alpha here. And that alpha parameter is what we call the intercluster correlation, or essentially the ratio of the outcome variance that's attributed to between cluster variation over the total variation. Or you can kind of think of it as how similar are two individuals in the same cluster compared to two individuals in different clusters. So this is kind of our measure of how clustered our data is. And the more clustered that data is, the farther away your effective sample size is getting from an individually randomized treatment effect or individually randomized control trial, because that larger ICC is going to inflate the ATE variance and then inflate the sample size that you need to maintain power compared to that individually randomized trial, because we have less independent information per observation in this space. So how do you account for the ICC? Some kind of fairly run-of-the-mill clustered or longitudinal data methods. You can use something like a linear mixed effects model with a cluster level random effect, or you can use something like GEEs with an exchangeable correlation structure. Pretty kind of bread and butter for most of us, I would kind of argue. Now, because of these kind of extra considerations that need to be taken into account when designing these trials compared to an individually randomized study, Consort released an extension in 2010 to kind of specifically call these things out, specifically calling out needing to consider individuals within clusters being non-independent, and the fact that when you do a cluster randomized trial, simple randomization is only going to guarantee balance on cluster level characteristics. It won't necessarily guarantee balance on individual level characteristics. So one of their kind of recommendations was if you were interested in balancing on non-cluster level characteristics, you should think about more complex randomization schemes. And we'll kind of return to that in a little bit. Now, old design, I would argue, even though they're still very much in use, the more common types of cluster randomized designs tend to go beyond this and tend to be in its kind of multi-period or longitudinal variations. And there are a lot of really well-known variations beyond this. We have things like multiple period designs that we see over here on the top left, where you're going to have repeated measurement observations for each cluster. So you'll be observing each cluster longitudinally, usually within the same treatment condition. Whether you longitudinally observe the individuals within that cluster depends on how you set up the study. You can have cross-sectional or longitudinal observation of individuals. You could have something like a cluster crossover trial, like we see over here on the top right, where instead of randomizing treatment condition receipt, we're now randomizing the order in which clusters are going to receive that treatment condition, which is going to increase your power compared to a kind of parallel CRT. But one of the downsides of this type of study is it really requires that intervention is able to turn on and off fairly easily, which in kind of the more pragmatic or kind of learning health system space, that's not always something that's super feasible. It's hard to kind of take a protocol out of a hospital system once you've put it in there. And so from this, a kind of more flavor of a cluster crossover trial kind of emerged as the step-wedge trial, where instead of having or bidirectional crossover of conditions, we can have this kind of unidirectional crossing from control to treatment conditions. And what you're randomizing here instead is the timing of that crossover instead of the order of the crossover itself. That's where we're going to be spending a lot of time today, because that's where I do a lot of my work. And then there are also flavors of design that I didn't have a good schematic for, but these ideas of multi-level or nested designs where you have some sort of intermediary clustering going on. So you can think of these as kind of individuals nested within subclusters, which are nested within kind of larger cluster structures. And randomization there can either be happening on the subcluster level or the larger kind of supercluster level. So all of these types of designs can be helpful because they can regain us some of the power that we lost in a parallel CRT when we compare it to individually randomized designs, kind of depending on the scenario. And they all deal with some kind of multiple levels of clustering. So if you're looking at longitudinal designs, you're going to have individuals that are clustered within time periods that are clustered within clusters themselves. And then in the case of these multi-level or nested designs, you'll have that kind of classic individuals nested within subclusters, nested within larger clusters. And like I said, I'm going to be specifically talking about step-wedge designs because it's a type of design that gets brought up by investigators quite a lot, because it looks like something that will solve a lot of their problems. And sometimes it does, and sometimes it doesn't, which we'll talk about. So the anatomy of a step-wedge trial is that we are still going to have individual clusters that we are going to observe longitudinally over the course of the entire study. And we call each of these kind of measurement occasions for a cluster period. So measuring clusters over multiple cluster periods. We can have individuals within each of those cluster periods, and individuals may be unique to each cluster period. So we're refreshing the population pool at each time period, or we might have kind of longitudinal observations of individuals across multiple periods as well. And what we're doing here is essentially randomizing each of these clusters to what we call a treatment sequence or a treatment step. So the timing at which they're going to cross over from the control condition to the treatment condition. And then ultimately our average treatment effect or our main treatment effect is going to be the treatment effect that is averaged across all of these periods, kind of at the most simple sense. Now, in these types of studies, sample size is not just defined by number of clusters and the size of each of those clusters, but defined by the number of clusters, what we call the cluster period size. So how many individuals are we seeing in a cluster at a particular time period, as well as the number of time periods we're observing over the course of the trial. And these are kind of attractive because they can be more powerful than parallel CRTs because we have these within cluster comparisons between treatment conditions as well as the between cluster comparisons within a particular time period. But because we're only ever observing one crossover per cluster, they're going to be less powerful than those cluster randomized crossover kind of bidirectional crossover designs. And these can be like very attractive study designs for a lot of teams because a lot of the things that we hear when teams are interested in doing a cluster randomized trial is they might not have the resources to implement a fully kind of parallel cluster randomized trial. So if you think of an intervention where you have a team that needs to go around to multiple clusters to train those clusters on the intervention, it might be difficult to do that training for half of your clusters simultaneously. So this kind of staggered rollout allows for the investigative team to move from site to site to do that training. Another reason it's often fairly attractive is that it can be the fact that all of the clusters are going to receive the intervention by the end of the study can be used as a recruitment tool. And kind of can help build rapport with kind of stakeholders that head each of the clusters. A lot of times they want to be a part of that intervention condition or have this idea that something is better than nothing, and can be kind of more powerful than saying, okay, we'll do a parallel cluster randomized trial and you'll still receive the opportunity to have the intervention after the trial ends. It usually ends up not being quite as attractive. However, a lot of statistical considerations need to go into step-wedge trials beyond your kind of typical parallel CRT. One is that because we are randomizing the timing of treatment receipt now instead of the actual what you are receiving, time is now going to be a potential confounder that needs to be accounted for, which should be kind of fairly obvious. So usually we do this by just including a like typical time period fixed effect of some sort, dummy variables for time periods, linear variable for continuous time, splines, kind of choose your favorite fighter kind of thing. And this can be quite important when it comes to the number of clusters you want to randomize to a particular treatment sequence, because if you are randomizing multiple clusters to a single treatment sequence, you'll be able to kind of tease apart some of those, what's a time period effect versus what's the effect of the treatment within an individual cluster. But when you just randomize a single cluster to a kind of treatment sequence, it's then going to be difficult to be able to disentangle that actual time period effect. So kind of a importance on making sure you are actually randomizing multiple units to kind of your treatment sequences there. Second of all is because we are now in this realm of like longitudinal designs, we need to account for multiple types of clustering or more complex types of clustering. So now we're not only just dealing with the clustering of individuals within a single cluster, but we need to think about the clustering of individuals within a single cluster period or within period ICC. The correlation between individuals within the same cluster in different periods or the between period ICC. And if you are looking at longitudinal sampling of individuals, you might also need to consider within individual correlation as well. And so in step-wedge trials, really the minimum amount of complexity that you need to incorporate into your trial is something like a nested exchangeable correlation structure that we have here, which you can either do by adding kind of cluster period random effects to your linear mixed effects model or this nested exchangeable structure to a GEE. But really important to be able to have that extra amount of flexibility compared to a parallel CRT. In addition, another kind of drawback to, additional types of complexities, but additional drawback to step-wedge trials is that they are at greater risk for bias compared to parallel CRTs because we kind of have this longitudinal dimension. So you need to be thinking about questions of, do we have any sort of time varying treatment effects that are going to be going on or likely to be going on? Thinking about how long it's going to take an intervention to really get going within a cluster, or are you going to have some sort of ramp up period that you need to account for? Are you going to need to be looking at kind of an initial spike of efficacy and then kind of like tails off a little bit the longer the trial goes on? You also need to be thinking about questions of within cluster contamination or self-selection bias if individuals know the condition status of a cluster. So if you have individuals going to clinics and they know that a clinic is about to introduce new services as a part of this trial, maybe they'll think of postponing their appointment for another month to be able to receive those services rather than making it now. So kind of trying to work out ways to prevent some of that kind of contamination from going on. And then in addition, mostly as a function of the types of questions and the types of teams that we're working in, we're often in this space where it's difficult to recruit a lot of clusters for these trials. And so we're often dealing with a small n problem. So kind of asymptotics may not necessarily hold in these situations, and we need to be thinking about kind of small n corrections. And this is mostly due to resource constraints and kind of the logistics of learning health systems. Small n problem kind of proliferates throughout cluster randomized trials in general, but I feel like is especially prominent in step-wedge trials themselves. Now, for all of these reasons, Consort released an extension in 2018 to kind of outline some of these specific issues. Some of the specific key methods considerations they outlined was needing to consider for that time confounding, repeated measures on clusters and participants potentially, thinking about within cluster contamination, thinking about time varying treatment effects, and then thinking about how are you going to be measuring time? Is it going to be kind of discrete time intervals? Are you going to be thinking about it continuously, being kind of very strict about that documentation? And for a lot of the kind of extra risk of bias that step-wedge trials undergo, they're really quite heavy-handed, I guess, with the recommendation that you need to include some sort of rationale for why you used a step-wedge trial rather than kind of any other cluster randomized design. What made those other cluster randomized designs infeasible for your particular kind of research situation? And then being quite specific about exactly what are the timing of the interventions and what methods are you using to adjust for time and correlation assumptions. So from these Consort extensions, us and some of the other people in the kind of step-wedge universe were quite interested in this idea of how are teams actually designing, analyzing, and reporting step-wedge trials in the healthcare space. And so this launched kind of two systematic reviews that we did in the last several years. Our first kind of parent systematic review was kind of headed by Pascal Nevins. And it focused on primary reports of step-wedge trials in the healthcare literature that were published between 2016 and 2022. And we wanted to focus on what we considered to be trials that were quote unquote big enough. So our kind of inclusion criteria was they needed to have at least 5 clusters to be considered as part of this review, which gave us about 160 trials to work with and extract data from. Then kind of throughout the course of that review, we really began to wonder, you know, what is going on with these trials where you're randomizing fewer than 5 clusters? Because to us, that just seemed like such an anomaly and such a different beast than these other trials. And as we kind of combed through more and more of the literature, we were finding more and more instances of these very small step-wedge trials. So from that, we launched kind of a secondary systematic review designed specifically to look at those very small trials. So we looked at the exact same kind of time period, but our inclusion criteria were trials that were randomizing between 2 and 6 clusters, which got us a surprising amount of 61 trials. I thought we were going to end up with fewer. So that's, a decent chunk for that amount of time. And in these reviews, we basically took a trial and assigned it to 2 statisticians for them to review independently, to fill out the data extraction sheet for that trial, and then come back together to resolve any discrepancies at a consensus meeting. And we were primarily looking at collecting data on kind of general descriptive characteristics of these trials, what kinds of randomization techniques were they using, how were they reporting baseline variables, what kinds of methods were they using to analyze the trials, what kinds of and are they using any kinds of covariate adjustment, and how much adherence to consort methodological guidelines was actually going on. And so I'm going to present the results of these reviews kind of in parallel, since they cover a lot of the same kind of ground. So to start off, we can look at the types of sampling structures that were used in these step-wedge trials. In both the kind of regular sized step-wedge space and the extremely small step-wedge space, we found that by and far, trials were using a cross-sectional sampling structure for their individuals. So you were refreshing the population pool at each kind of cluster period observation. And so in these sorts of settings, it's going to require at least a nested exchangeable structure in the design and analysis of these trials. Kind of to a lesser extent, we saw some closed cohort sampling going on, and then a decent amount of open cohort sampling happening as well. When it comes to sample size, within the kind of regular size step-wedge setting, we had a median of 11 clusters randomized per trial, which I kind of want to point out is very much safely within what we consider that general small sample size classification in kind of the clustered, data work setting, which usually, you would need around 30 or 40 clusters for asymptotics to really be working well. So 11 clusters is, you should definitely be thinking about, small sample adjustments in this case. In the kind of small sample setting, obviously we had a much smaller number of clusters that were being randomized, but kind of around the top end of our inclusion spectrum, a median of 5 clusters that were randomized there. And it's just kind of an aside, among those, we found that about 84% actually reported a sample size calculation to back up that sample size, which I personally found surprising because I assumed that most of these trials were coming up with that number of clusters just because it was what was available to them, not necessarily through an actual sample size. So I was actually fairly surprised about that, and we can kind of get into the implications of some of these kind of small n analysis methods and how that plays into small sample size as well. Next, we can talk about kind of randomization techniques and analysis methods. Fairly similar across the two reviews. Unrestricted randomization techniques were the most common, which means that we're not going to have any guarantee of balance among kind of individual level characteristics, and they were kind of much more common among the small step-wedge trials as well. If you were going to use some sort of restricted randomization technique, stratification tended to be what you went with. As far as analysis methods, it's not really surprising that GEEs and linear mixed models were the most popular, and kind of among those, mixed models tended to be a lot more common than GEEs, and we think that's mostly because of the proliferation of kind of closed form sample formulas for mixed models compared to GEEs. It's just a slightly more accessible literature, we think, than the GEEs, although the GEEs are kind of coming back around. In addition, we saw that most trials were at least adjusting for time periods, which was great. More of them could do it, but we'll take 75%. And the majority of them were also adjusting for some amount of clustering, doing at least a within period ICC. But unfortunately, we only saw about 8% that were incorporating some sort of distinct between period ICC. So actually incorporating at least a nested exchangeable correlation structure into their studies, which is, falling down on one of kind of the basic tenets of designing any kind of longitudinal cluster randomized trial, much less a step-wedge trial. And we didn't really see a difference in that metric before or after that consort extension was released, recommending that you actually do that. Now, within small step-wedge trials specifically, we also looked at whether people were giving justifications for using step-wedge trials and using such a small number. We found that, about 70% at least stated a reason. And some of the most common were they wanted to use step wedge to facilitate recruitment, which wasn't particularly surprising. And they did it for kind of logistical or administrative convenience, also not particularly surprising. One of the ones I also like to point out was the relatively high percentage of trials that justified step wedge trials by saying that they wanted to improve the rigor of what they were doing. And as someone that works a lot in learning health systems and kind of pragmatic trial spaces, this actually wasn't very surprising to me because a lot of times we will have studies where you'll have a system that's wanting to roll out an intervention, like something is going to happen anyway, but the hospital leadership or something like that feel very strongly that they want to actually document the effect of that change and kind of improve the rigor of, the actual justification for why are we doing this change? What did it actually do to our system? So that's kind of the explanation of the rigor part. In these trials, very few people discuss the small number of clusters they randomized as a limitation, only about a quarter of them. And among those quarter that said that they were a limitation, most of the reasons that they stated for having a small number of clusters were basically they were the only clusters available. We didn't have enough resources. We had feasibility constraints, which wasn't that surprising to me. And back to both of our trials together, we also looked at how many of them used small n corrections or methods, which we kind of defined as using some sort of cluster level analyses, permutation or Bayesian methods, degrees of freedom corrections or some sort of GEE variance corrections. And kind of in both, we found that they were fairly underutilized, which wasn't great because in both settings, we found a great number of trials would have actually qualified and probably would have improved from using these methods. So what did we kind of learn from this review? We learned that randomizing a small number of clusters really continues to be prevalent in step wedge trials. More than 25% of the trials we looked at randomized 6 or fewer clusters, which is way below that small n threshold. So you might not have the asymptotics for power estimates holding there. As kind of an anecdotal observation, I found that quite a number of these were actually naively designed multi-level step wedge trials. So the randomization was done on clusters of clusters. So it's not quite as bad as it could be. There's still room for improvement, but it's not just purely people just randomizing super small numbers of clusters because they think they can get away with it. We also found that really few studies were allowing for appropriately complex correlation structures, and we kind of hypothesized that this might be contributing to the fact that studies are using and randomizing overly small numbers of clusters, because if you aren't allowing for an appropriately complex correlation structure, your power estimates aren't necessarily going to be correct, and you're more likely to be underpowering your trial than kind of going on the other side and overpowering it. And then finally, we found that unrestricted randomization methods dominate. So this gives us a greater chance for kind of individual level imbalance, especially in those cases where you have clusters that are what I call like unique or distinct. So clusters that are maybe contributing the entirety of the presence of a subpopulation in a trial. Using unrestricted randomization is really going to complicate our being able to analyze the effects on that subpopulation and how that subpopulation, how they might have differential treatment effects necessarily, especially if that particular cluster came very early or very late in the trial. So they were kind of observed in an unbalanced number of cluster periods on one treatment condition or another. So why is this happening? We don't really know. This is, me kind of speculating. It could be that study teams just aren't aware of the breadth of methodological guidance that's available, because that guidance is out there and it's available. But it's been 7 years since that consort extension, so that's probably not it necessarily. It could be that we have a lack of widely available software tools, which is certainly a possibility. A lot of the methods that we have developed and the guidance that we have developed have been kind of more on the theoretical side and haven't really made its way into being able to use them without coding them up yourself. It could be that there is a lack of access to appropriate design parameter information, and particularly a lack of access to what investigative teams should be setting as their kind of ICC parameter values when they're designing these studies. So, for example, you might have a team that knows they should be using a nested exchangeable structure, but they just don't have the kind of literature or historical data to be able to inform what that value should be for the between period ICC. And this is kind of built up where it's getting better, but reporting of outcome ICC still remains relatively poor. And I'm kind of on top of that. ICCs are notoriously sensitive to the types of outcomes that are used and the definitions of the clusters that, in the types of trials that they were used in and the length of the time periods. So it's a lot of times it's the case that even if you do find an ICC for the outcome that you're going to use in your trial, it might not necessarily map to your particular trial setting. And so this is a problem, not just in step-wedge trials, but for cluster randomized trials in general. And then finally, it could be that like a lot of the available methods that are out there aren't sufficiently flexible enough, that people are looking at a particular tool that they have and going, well, I can't use the sample size formula because we're doing our own kind of adjustments on this. So it's not going to be sufficiently complex enough or something like that, because a lot of these types of studies aren't necessarily out of the box designs. So how do we kind of overcome some of these causes? There have been several tools that have been developed over the years to help with this. When it comes to lack of parameter information, you have the Cloud Bank database that was released in 2021, as well as some tutorials around how you can go about different ways of estimating your ICC for kind of trial design. On the kind of lack of software space, the Shiny CRT calculator developed by the kind of Monash group has been super helpful in terms of being able to bring together a whole bunch of different types of methodologies into one place and allow people to really play with designs without having to do a lot of coding. There's also been kind of a couple of reviews about other types of software across different platforms that have been available. And these tools aren't mine. I'm not affiliated with them. I just think they're really cool and I like to talk about them when I can. And we've also kind of more recently been thinking about what happens when we want to move beyond kind of trials that are just interested in main treatment effects and start thinking about how we can incorporate treatment effect modification or treatment effects among subgroups into cluster randomized trials. And in that space, my current contribution is this CRT HTE Shiny Calculator that we've just released a preprint for as well, that kind of helps with some of that lack of software and parameter uncertainty a little bit. So I'm briefly going to talk about the Cloud Bank database and the Shiny CRT calculator, and then hopefully have a little bit of time to talk about my HTE calculator. So the Cloud Bank database, we have like QR codes up in the top corner for people that are interested, is this really neat kind of Shiny app that's been put out. That's the clustered outcome data set bank of intercluster correlations. It's basically a repository of 29 clustered data sets that have longitudinal observation. And they've done a really nice job of kind of categorizing these data sets by the types of trials that they were done under, as well as the kind of lengths of time that they were observed, the types of clusters that they were including, and kind of the conditions in which that trial was conducted. And basically, it allows you to search among all of these data sets to look at different study characteristics and the types of outcomes that were used, and be able to, they also calculated the ICCs for outcomes collected within that study under kind of different assumptions of model complexity. So they look at kind of regular exchangeable, nested exchangeable, and block exchangeable, as kind of well as some other things as well as multiple outcomes that were included in each study. And I don't have the slide here, but they also have this really nice box plot tab that can show you the kind of spread of the ICCs for a particular type of study characteristic, to give you kind of an idea of the spread of ICC you might be trying to target in your particular trial. So I think this is really pretty key for at least trying to stop the gap of trials just not having any information to be able to go off of whatsoever. I also find it's really helpful because 22 of those data sets are actually public access repositories. So you can go in and get deeper into that data if you want to. And I oftentimes use this as like a search tool for clustered data sets to use in teaching, which is kind of nice. The second one I wanted to talk about was the Shiny CRT Calculator, which was released by kind of Carla Hemming and others. And this is a kind of an online sample size and power calculation app for the main effects in cluster randomized trials, where it supports kind of multiple types of trial designs, multiple types of outcomes, and gives you the option to calculate using some kind of limited types of small n corrections. They have kind of a nice mix of the types of correlation structures you can implement, and kind of gives you some really nice plots in terms of being able to look at how your sample size is affected by kind of ranges of ICCs, as well as kind of directing you to additional resources if you're willing to kind of like dig into it a little bit more. And it's kind of from this calculator that we took a lot of our inspiration for extending it to the heterogeneous treatment effect space, which is what I'm going to talk about next. And in the kind of heterogeneous treatment effect space, we found that there's a growing interest in evaluating if there are differential treatment effects among pre-specified participant subgroups. A lot of ways to define subgroups, but kind of the key element that we're trying to get at here is that we weren't really interested in the assessment of heterogeneous treatment effects in a kind of hypothesis generation or kind of data-driven subgroup kind of manner, but more in this is a question that we have thought about as we're designing the study, and we would like to answer it with appropriate power kind of at the offset. And so there are a lot of reasons why you might be interested in these types of hypotheses. It could be from kind of a treatment optimality motivation. You want to see if your intervention works particularly better in kind of high-risk subgroups. You might also be looking at it from more of a health equity standpoint. You're trying to make sure that you're not having differential treatment effects among subpopulations when you didn't intend for there to be differential treatment effects necessarily. And so the way a lot of times that we look for these heterogeneous treatment effects is, just via a simple interaction between some sort of subgroup covariate X and the treatment variable. And when we're testing for the presence of a heterogeneous treatment effect, what we're doing is testing the null hypothesis of this interaction term, as opposed to doing a hypothesis test on the treatment effect among a subgroup necessarily. And so because these hypotheses are pre-specified, we want to check to make sure that we have appropriate sample size and power for them, but to design a cluster randomized trial for a heterogeneous treatment effect, you have to think about slightly different parameters and slightly different considerations than you would necessarily for a cluster randomized trial focused on an overall or an average treatment effect. So first, and probably the most obvious, is that when you're calculating sample size for these interaction tests in a cluster randomized trial, you have a completely different variance going into it. And what's key here is that the variance of the HTE in cluster randomized trials not only involves terms of the outcome ICC, but we also have to account for what we call the covariate ICC, or how much clustering is going on in our kind of subgroup value here. And this is usually a parameter that investigative teams aren't as familiar with and kind of are a little bit weary of, because first of all, they're, oh no, I have to find another value for another parameter that I don't know anything about. And kind of having to add more in that way. So needing to think about, again, even more levels of clustering going on here.
Sorry to interrupt, but question about that is, does that parameter capture, like if you look at these clusters and you're testing heterogeneity with a covariate, you mentioned sort of, you had race and ethnicity up there, assuming that would be highly correlated with clustering, right? It's particular communities that you're going into that will have particular subgroups of individuals. Is that this parameter captures that clustering? Or is there more to it? Because I think it seems to me like the clustering effect in your random effects model is going to be very much related to this covariate potentially across clusters. So like, does that make sense? Or
Yeah, so the way we basically account for the covariate ICC is basically if you were to look at it doesn't involve the outcome at all, but there can definitely be, I guess, an interaction between the two. Usually when we're thinking of covariate ICC, we're looking at, if we think of it in terms of like a binary covariate, how much variation in proportions of that binary covariate do we have among all of our clusters necessarily? So basically, what are the differences in prevalences among our different clusters? Does that?
among the different, not across them, but among them.
Yes.
Yeah, okay.
Cool. Thank you. That was a good question. Cool. So a lot of times people are freaked out by covariate ICCs a little bit, but they're not necessarily as burdensome as you might think most of the time because of how covariate information is defined in these. A lot of times the covariate ICC structures we need are simpler than the ones we would use for the outcome ICC. Mostly because a lot of times these subgroups are defined on baseline characteristics, so they're not necessarily changing over the course of a longitudinal study. So you don't have to define quite as many extra variables as you might think. On top of the fact that a lot of times this covariate information is a lot easier to obtain from historical or observational data than you would necessarily get from the outcome, because a lot of times these subgroup characteristics are things that we just commonly collect in lots of data sets, whereas a lot of times those outcomes are very specific to kind of very contextualized circumstances. So you might actually have more data to be able to estimate your covariate ICCs than you might have kind of previously thought. So maybe not as hard as you thought it was going to be. And on top of that, when you compare kind of the HTE design effect to the ATE design effect, we find that the design effect for touching the ATE and parallel CRTs is actually bounded from above, whereas the design effect for ATEs is unbounded. So we find that when you are powering a cluster randomized trial for the overall effect, you may have actually accumulated a sufficient sample size in the course of that to actually be able to test a pre-specified HTE. So kind of in trying to get to the appropriate power compared to an individually randomized trial, you might not actually have to boost your sample size all that much to get to the appropriate sample size for an HTE here. And we kind of see that over here with this figure from Yang et al., where a lot of times these curves can be kind of quite flat when it comes to the ratio of the HTE and the ATE sample size. And it kind of depends on what your outcome and covariate ICCs are. But when you are looking at effect sizes that are fairly comparable, you actually won't need to boost your sample size very much. Now, whether you're looking at an HTE that is of the same magnitude as the overall treatment effect is another matter, but it could be that maybe you're not needing to do quite as much as you previously thought, which is kind of I think a little bit in contrast to what we see a lot of times in individually randomized trials, where testing for a heterogeneous treatment effect usually does mean that you're going to have to boost your sample size quite a lot to be able to get there. So in the course of this, we have the theory that's there to be able to design these studies, but there are a lot of kind of barriers that get in the way of people actually being able to implement them. A lot of times you'll have study teams that are considering multiple variations on a single study design or kind of multiple types of study design. So you're wanting to weigh differences in power against kind of differences in logistical and resource constraints. You might also want to design these trials with more tailored simulations than what be out there in the methodology. But I think it's usually important to, before you go into those tailored simulations, to try to reduce your decision space a little bit, reduce the number of scenarios that you're actually looking over. And, a lot of times barriers end up being, they're all over the place. You need to flip through a bunch of papers, or, those formulas, aren't even available in software yet, so you would have to code them up yourself. So because of all of these things, that kind of led us to wanting to develop this calculator application specifically for designing cluster randomized trials around the heterogeneous treatment effect. Which is, as you can kind of see, it looks very similar to the regular Shiny CRT calculator. We've kind of taken some additional kind of adaptations of additional methodology that's been developed over the years and some differences in sensitivity that goes into the outcome in the covariate ICCs. And we've also written up kind of a tutorial and reference guide that goes along with it that we have a preprint of now. And I'm just going to briefly, it looks like a Shiny app. It shouldn't be all that surprising. You can scroll for more input options. Your kind of main output is this power plot that will change depending on the plot display that you choose. And then you have kind of other additional main panel displays that you can choose from. And the way we kind of set up this workflow is to kind of mimic how you would necessarily think of the design parameters and doing this kind of by hand, where the kind of choices you make for the inputs up top are going to filter the amount of choices that you're going to have to make for inputs down below. So those kind of options are reactive to your choices. And so then the kind of final output is you get these kind of nice interactive plots that give you kind of hoverability and clickingness. And you can have kind of multiple views to see how power will change for kind of a range of outcome and covariate ICCs. And if you want to define instead of just a single ICC estimate, you want a range of maybe like plausible ICC estimates, you can get kind of multiple lines to be able to look at that. So I know I kind of blew past that last part, but I feel like I need to include it, but I'd like to talk about my systematic reviews a little bit more because I feel like they're a little bit more interesting. So kind of to conclude, a lot of stepwise trials don't adhere to consort guidelines. They kind of violate them in randomizing very few clusters and using inappropriate correlation structures, and there are kind of a range of reasons they might do that. There are tools that have been developed to help. And when it comes to looking at these trials in a heterogeneous treatment effect space, we've also developed additional tools there. A lot of questions I usually get when I talk about this is that, sample size calculators are nice, but, what's the line with, doing just by hand sample size simulations for the actual kind of tailored thing that I want. And on that point, I feel like I can say that these tools can still be helpful for even the kind of very seasoned, code proficient statistician, because they can be kind of useful starting points to whittle down your kind of decision space to direct you to kind of more complex simulation analyses. And on that, I have my collected references, and thank you all very much for having me.
Thank you very much. Any questions from the room, online?
I have one question.
Mm-hmm.
Yeah, it's a very nice talk. Thank you for explaining the stepwise design so thoroughly. You said like the number of a cluster is more important than the size of cluster itself,
Mm-hmm.
right? So in this scenario, can you clarify? So if I have a 6 cluster, each
Mm-hmm.
cluster have 100 samples,
Mm-hmm.
or another scenario, you have a 60 clusters, but with each cluster will have smaller, like 10 participants. So total sample size 600. So you prefer the 60 clusters, or what's the relationship with the size of cluster and the number of clusters?
Yeah, generally it's going to be you prefer the larger number of clusters versus a smaller number of very large clusters. It's going to depend on like how big the differences in power is going to depend on how big your ICC is. So if you have a very large ICC, your effective sample size is going to skew more toward the number of clusters than it is to the kind of grand total number of people you have enrolled. Is generally how that tends to work. But there is some sort of balance that usually needs to go on between, the two, because sometimes you just don't have 60 clusters to be able to recruit, so.
Okay, thank you. So another related question about the steps, number of steps. So sometimes I have a 60, suppose I have a 60 cluster. The reason I use the 60 because for our HPV vaccine and we are able to recruit like 60 clinics here. So if we design the number of steps we're using for one step, we group those clusters. So each step, if we have a randomly choose 10 of those cluster to do, or we reduce the grouping and increase the steps. So what's the relationship with the number of steps and the number of clusters
So
for
the
the
number,
intervention?
yeah, so the number of steps usually, ideally you want to have multiple clusters per step as opposed to one cluster per step, because then you'll be able to kind of tease apart time effects. Generally, the number of steps you want to, the effect of the number of steps on power is slightly more complicated, but I feel like most of the time people are choosing the number of steps to kind of align with how much time do they have to run the trial. So like how long is a step going to be? And if you know if a step is going to be 6 months, do you have time to run a 3-year trial, or do you only have time to run, a year and a half trial? So kind of on
Yeah,
that
the
front as
step
well.
is bounded by the study duration, maybe. Yeah, okay. Thank
Yeah.
you. Thank
Yeah,
you,
no worries.
Mary.
Yeah, that tends to be a more practical consideration.
All right, there is a question from Lee online regarding the unstructured matrix in a GEE in the chat.
I mean, the thing with an unstructured matrix, it's technically fine, but I feel like if you have very unbalanced, if you have like a lot of unequal cluster sizes, the unstructured correlation matrix can get fairly unstable in GEEs, as well as ideally when you're planning a cluster randomized trial, you're wanting to align the methods that you're going to use to analyze the trial with the methods that you're using to design the trial. Because if you use kind of a different model to design the trial from what you're actually going to use to analyze it, that power estimate might not necessarily map over. And one of the issues with unstructured matrices is it's very hard to figure out what that matrix is going to look like at the design stage necessarily. So that's usually, I feel like, one of the main reasons why we don't end up using it in trials is just like when we're designing it, we have no idea what that's going to look like. On top of kind of, unbalanced clusters can make that a little bit unstable. But there are scenarios where the kind of unstructured matrix is fine for the kind of analysis portion. It can work.
Thank you.
Thank you. We're a little over, so I think we'll end there and thank the speaker again. Room, online. Yeah, if you have further questions, feel free to contact the speaker.